Hi, my name is Greenfield, and this will be a review of the causes of vertigo. This is a review of what I'll be covering in this presentation. What is vertigo? It's defined as a type of dizziness characterized by sensation of spinning. Either the environment is spinning or the patient is spinning. Other symptoms associated with vertigo include nausea, vomiting, sweating, and the general feeling of being unwell. To put it simply, it's caused by a mismatch of sensory inputs from the vestibular system or a disruption in the interpretation of signals within the nervous system. Vertigo is a unique type of dizziness that many patients might not know the specifics of. There are other types of dizziness that can feel similar to vertigo, and they can happen simultaneously. They can be triggered by the same thing, like sitting up quickly. This can make it difficult to determine what's actually happening. Dizziness is defined as a transient sensation of lightheadedness, imbalance, and disorientation. Vertigo is a strong sense of motion or spinning. Disequilibrium is the feeling of being off balance, unsteady, or wobbly. Lightheadedness is defined as wooziness or being disconnected from the environment. Presyncope is a feeling of losing consciousness or about to faint. Some other causes of dizziness include hypoglycemia, hypertension, and anxiety. Vertigo is often divided into two categories, peripheral and central. This describes where the source of the problem is. Peripheral vertigo is caused by disturbances at the inner ear that interfere with the creation and broadcasting of the signal. Central vertigo is caused by disturbances in the central nervous system. It can be broken down further by pathology, but for the most part, all peripheral and all central causes present the similar symptoms. In the table on the right, these two types of vertigo can be broken down by their general symptoms. Peripheral causes of vertigo are caused by problems with the hardware of the vestibular system. It's often positional, and it's caused by lesions in the vestibular nerve or disturbances of the inner ear. BPPV is the most common pathology associated with vertigo. It stands for benign paroxysmal positional vertigo. It's caused by crystals of calcium carbonate, called otoconia, that line the inside of the canals that get displaced into the canal, which disrupts the normal flow. When you turn your head, the crystal causes a delay of movement of the fluid, called the endolymph. The brain relies on the signals generated by the movement of the fluid through the canals to tell if the head is being rotated. If there is a displaced crystal in one of the canals on the right, then the signal's timing and magnitude would not match the signals from the left. This mismatch of signals is what causes the sensation of vertigo. Episodes of BPPV are triggered by rotational movements of the head, like quickly turning your head, laying down, sitting up, or rolling in bed. This is why it's considered positional. Episodes last anywhere from a few seconds to about a minute, however long it takes for the crystal and the fluid to stop moving. Typically, the episodes occur over several weeks until the crystal is reabsorbed by the body. BPPV is benign and can resolve without treatment, but it can be very disruptive to an individual's life, so treatment is often sought out. The diagnostic test is called the Dix-Hallpike maneuver, which is a combination of head and body movements that are likely to recreate the symptoms. The treatment is called cannula reposition procedures, or Epley maneuvers, or the modified Epley maneuver, which is the same as the test plus a few more specific movements to reposition the crystal in a place where it will not interfere with the flow of the endolymph. Another big feature of vertigo is nystagmus. It is the normal response of our bodies when we turn our heads quickly. It's called the vestibular ocular reflex. During an episode of vertigo, it repeatedly occurs because the disrupted signals are telling your brain that you are spinning. It's characterized by a slow movement of the eyes occurring in the direction opposite to the head rotation, followed by a fast movement in the direction of the head rotation. To replicate this phenomenon, sit in a chair that can spin, and spin quickly for a few seconds. Quickly but safely stop spinning. You should feel a spinning sensation, but you may also feel the vestibular ocular reflex controlling your eyes, making them beat towards the direction you were spinning. You can also have someone else do this and stop them quickly and look at their eyes and watch this happen. Observing the direction and duration of the nystagmus can also give us more information about what the source of the problem is. A horizontal nystagmus can be either peripheral or central. A vertical or rotary nystagmus are only caused by central causes. Other causes of peripheral vertigo include Meniere's disease. It's caused by the buildup of fluid in the inner ear, which also disrupts the flow, which in turn disrupts the signal. Its cause is unknown, but it runs in families, so it is thought to have a genetic predisposition of having increased production of indolence. The attacks last several hours at a time. During these attacks, the patient may experience tinnitus, fullness of the ear, and hearing loss. It is most often seen in middle-aged adults and is not triggered with movement. Other causes include vestibular neuritis and labyrinthitis, which are caused by viral infections, which result in the inflammation of the vestibular nerve in vestibular neuritis and inflammation of the labyrinth in labyrinthitis. Vestibular neuritis does not cause hearing loss, but labyrinthitis can. All three of these pathologies can be treated with antibiotics or antivirals and NSAIDs, and they can all spontaneously recover. The central causes of vertigo are caused by disruptions of the delivery or interpretation of the signals coming from the vestibular system. The location of the issue is often in the brainstem or cerebellum. The sensation of vertigo is more mild with central vertigo than with peripheral vertigo. The symptoms are sustained, unlike peripheral, which come and go in episodes. Also, it is non-positional. Posterior circulation infarcts, also known as strokes, can cause vertigo. The onset is sudden, but often accompanied by ataxia, diplopia, and cranial nerve defects and lung weakness. Tumors can also cause vertigo. Often the tumors are in the brainstem or cerebellum, and the associated symptoms can be similar to a stroke, but the big difference is the onset is gradual. Vestibular migraines can cause vertigo. The episodes last 4 minutes to hours. Vestibular migraines can also cause visual auras, like in the picture above, and headaches. Multiple sclerosis is the last common cause of central vertigo I wanted to mention. The symptoms are often relapsing and remitting, and other symptoms include optic neuritis, which causes pain and vision loss, and transverse myelitis, which is inflammation of a section of the spinal cord. So how do you determine the cause? First, consider the objective information. Was the onset sudden or gradual? Is it triggered by movements of the head? How long do the episodes last, or is it constant? Is there nystagmus, and what direction is it in? How old is your patient? Is your patient male or female? And does the patient have any other symptoms? Next, consider any objective information you have, and if any more tests need to be done. The Dix-Hallpike maneuver is often the first test. It is non-invasive and can quickly identify BPPV. Another clinical measure is blood tests to check for signs of infection. It helps determine if it's vestibular neuritis or labyrinthitis. The Romberg test, or the Fukuda maneuver, measures the subject's abilities to maintain balance by using their proprioceptive, vestibular, and vision systems. It's not exactly a vertigo test, but more of a vestibular function test. And CT or MRI scans can help identify infarcts or tumors. Vertigo can sometimes have uncertain etiology. Tests may be inconclusive, symptoms may be recurrent, you might get some improvement, but not a full recovery. So another diagnosis of vertigo I want to mention is PPPD, which stands for Persistent Postural Perceptual Dizziness. It's a processing disorder that can cause dizziness, postural instability, and vertigo. The cause of vertigo ultimately determines the treatment. Canalith reposition movers are only effective for dislodged crystals of BPPV. Medications are used to treat associated symptoms and infections. VRT training, or vestibular rehabilitation therapy, consists of head-eye movements with various body postures and activities, and maintaining balance with a reduced base of support with various orientations of the head and trunk, while performing various upper extremity tasks, repeating the movements provoking vertigo, and exposing patients gradually to various sensory or motor environments. Habituation, which is a part of VRT, its goal is to reduce the magnitude of the response to repetitive sensory stimulations. It is induced by repetitive exposure to a provoking movement. Imbalance training. We can't always treat the cause, but we can help by reducing the risk of falls through strengthening and proprioception training to help by decreasing the reliance on the vestibular system. To review, vertigo is a type of dizziness characterized by a spinning sensation. The two categories are peripheral and central. Symptoms to look out for are the onset, the intensity, duration, the nystagmus direction. Does the patient have hearing loss, tinnitus, or fullness of ear? Are there any cranial nerve or brainstem defects? If the cause is identified, start with treating it. Progress with VRT if vestibular function does not fully recover.